LGUs are at the forefront of managing COVID-19 cases within their communities. And during these challenging times, LGUs need to arm themselves with information. In this video, we will provide local chief executives with actionable standards on the 6 areas of case management that they can calibrate according to the needs of their locality. These are the Incident Command System, Border Control, Testing, Contact Tracing, Isolation and Quarantine, and Referral System. An Incident Command System, or ICS, is a standardized structure that enables cooperation amongst the government, the private sector, and civil society organizations, or CSO, in times of crisis. The DOH recommends an ICS structure organized by the provincial government and representatives or municipal governments and barangays. The organization is headed by an incident commander, followed by a public information and liaison officer. These officers are tasked to oversee 4 main units: planning, operation, logistics, and administrative or finance units. Under the operations unit are 4 clusters. First is the health cluster, which includes barangay health stations, barangay health emergency response teams, and city isolation units. The remaining 3 clusters are the food and social security cluster, peace and order cluster, and management of the dead cluster. Aside from the recommended structure by DOH, the National Task Force Against COVID-19 also provided a guide on establishing an emergency operations center at the city or municipal level. The proposed EOC structure is headed by the local chief executive, who is supported by 2 deputies, one for administration and operations and another for medical services, who shall work with national agencies such as DOH and DILG. Data collection, analysis, and management section, as well as a secretariat, appears under the deputies. Under these roles are 16 clusters assigned to perform specific tasks related to public health, logistics, communication with the community, and legal and compliance monitoring. The aim of creating such a comprehensive structure is to create a centralized command system in which there is a lead decision maker and a corresponding set of teams prepared to perform their corresponding responsibilities. The second area is border control. This refers to the measures taken to regulate the movement populations across countries to prevent the transmission of COVID-19 to local communities. Local chief executives, especially those whose localities have passages for trade and tourist activities, need to place border control measures in place for overall public safety. An effective border control should work alongside other pandemic response strategies, such as quarantine protocols and further management of confirmed cases. To reduce the risk of local transmission, health agencies and COVID-19 task forces should conduct exit and entry health screenings for departing and arriving travelers at the points of entry or POEs. The screening involves 2 stages: primary and secondary screenings. Primary screening involves the collection of data on travel history, exposure, and body temperature, while secondary screening refers to a follow-up assessment by a healthcare professional for travelers with signs of illness or declared exposure risk. POEs should also allow the risk communication team to inform the public about transmission causes, self-monitoring process, recommended care, presence of local transmissions, and the emergency hotlines, news websites, and other credible sources they can access. Other than the mentioned requirements, the U.S. Centers for Disease Control and Prevention recommend specific resources in implementing public health screenings at points of entry. Screening facilities require the following requirements: sufficient funding to support screening supplies and equipment, salaries of personnel, and other quarantine necessities. Additionally, all operations should be in line with clear protocols for primary and secondary screening based on information collected. An adequate number of trained personnel, their PPEs, and non-contact screening tools are also needed to successfully carry out screening and administrative tasks. And to accommodate quarantine travelers, travelers, resources such as food, water, medicine, sanitation kits are required. Referral healthcare facility and isolation area with beds, chairs, and other features to maintain hygiene care are also vital to accommodate ill travelers. And lastly, access to network signals and other communication channels should be readily available so quarantined travelers can stay connected with their families and friends. To create more streamlined public health screening processes, the NTF against COVID-19 recommends the screening for the following classifications set by the DILG: the LSI, RR, ROF, and APOR. The first classification is locally stranded individuals or LSIs, which refer to foreign nationals or Filipino citizens in specific locality who have expressed intention to return to their place of residence or home origin. The next are returning residents, who are LSIs, who are set to return or who are returning to their place of residence or home origin after being stranded in various localities. Citizens returning to the Philippines from abroad fall under the Returning Overseas Filipino classification. They can vary from overseas Filipino workers, non-overseas Filipino workers, returning Filipino diplomats or tourists, participants of Philippine government-sponsored programs accompanying foreign spouses, among others. The fourth and final classification is Authorized Person outside residence. Individuals belonging to this category are those whose job in essential sectors involve movement across borders. Usually, these are workers who are part of health, emergency, and funeral frontline services, security forces, food and medical manufacturing, banking and capital markets, telecommunication service providers in media, energy, water, and sanitation workforce, government skeletal teams, and authorized humanitarian assistance groups. Additionally, one private individual per household is also allowed to buy necessities and access essential services. During the screening process, the individual is required to fill in a registration form. Here's how a basic registration form looks like. Other documentation such as travel orders, medical certificates, or proof of negative RT-PCR results are required as appropriate for each type of individual. Shown in this figure are the corresponding requirements per classification. Local chief executives must assess the varying levels of risks of the border protection staff being exposed to hundreds of travelers. According to the U.S. Department of Labor, there are 3 levels of risk involved in border protection tasks. First being low caution, which includes administrative duties in non-public areas of work sites and routine transportation security activities not involving the traveling public such as cargo inspection. Next would be medium caution, which underlines routine border security activities including passport review of travelers and routine transportation security screening activities at passenger checkpoint. High caution, being the high level of risk, involves getting close contact with suspected COVID-19 travelers and entering isolation rooms such as during augmented screening steps. We have testing as a third area of case management. A rigorous and responsive testing system is vital to prevent the spread of communicable diseases such as COVID-19. Information extracted from tests is critical to decision-making since such data is used to predict, prepare for, and respond to a pandemic. As such, testing information also helps experts and key respondents to monitor and track the virus to slow its spread. There are 3 different tests for COVID-19, and they work in different ways. The first is reverse transcription polymerase chain reaction, or RT-PCR test, which serves as the gold standard for COVID-19 testing, being the most used and widely studied method to date, which has the highest sensitivity and specificity. The next is the antigen, which is most helpful when immediate results are needed. However, it has lower sensitivity than RT-PCR. This test can detect COVID-19 positive patients when they have high amounts of the virus within in the body, usually within 1 week of the onset of symptoms. Those with low amounts of virus in the body or were tested more than a week after the onset of symptoms can receive false negative results. And the last type is antibody test, which is used to detect past infection or as treatment management to monitor a person's full recovery from COVID-19. Dealing with biological material can expose risks to laboratory staff and the environment. For this reason, testing laboratories must meet certain standards. Testing for SARS-CoV-2 requires a biosafety laboratory level 2 facility with biosafety cabinets, PCR cabinets, real-time PCR machines, and personnel trained in performing the procedure. And since not all LGUs have adequate resources to establish their own testing laboratories, they must coordinate with other health facilities with high-level testing capacity. But for LGUs that have sufficient funds to set up a COVID-19 testing center, they should follow the following steps in compliance with the Research Institute for Tropical Medicine or RITM's protocols. First, the interested organization must write a letter of intent addressed to the DOH Undersecretary of Public Health Services. Following this, they will be asked to accomplish a self-assessment tool from DOH, who will then follow through application based on an assessment conducted with representatives from the RITM, WHO, and the Health Facilities and Services Bureau. Once the application is approved and the facility is established, the laboratory technologists are to undergo a proficiency test. After only passing the test will the laboratory be permitted to operate as a COVID-19 testing laboratory. The newly operational laboratory is required to submit to RITM the first 5 positive samples for confirmation. Then, if there is good concordance between the newly operational laboratories and RITM's results, the laboratory can commence COVID-19 testing independently of RITM. Following efficient testing, contact tracing, the fourth area of case management can break the chains of transmission of the virus. According to the Centers for Disease Control and Prevention or CDC, it entails monitoring patients with suspected or confirmed infection and helping them recall and identify people whom they had contact during the time of their infection. The pandemic has increased the need for the country to rapidly gather real-time data and indicators for rapid identification and the improvement of our healthcare resources. For this reason, the Philippines adopted a granular approach to contact tracing administered by Barangay Health Emergency Response Teams or BHERTs. 1 birth is assigned for every 1,000 people in the community, and each unit consists of at least 5 people, an executive officer to manage the whole operation, a doctor, nurse, or midwife to manage health workers, a barangay tanod to conduct monitoring, inspection, and other peace and order activities, a barangay health worker to attend to the patients, and a volunteer to assist the operations. Their responsibility can be broken down into 6 aspects: to serve as navigator of the local contact tracing team in locating individuals and their close contacts, to assist the patient in finding the optimal area for self-isolation at home, to facilitate the transfer of the patient to the community quarantine or isolation unit if necessary, to monitor the condition of people under quarantine, to send the patient's recorded symptoms to the concerned officials, and to ensure the completion of the prescribed home quarantine period for patients and families undergoing it. To effectively execute contact tracing, the workforce is required to undergo training to be equipped with requisite knowledge and skills such as an understanding of data confidentiality, broad knowledge of medical terms and case investigation, core components, excellent and culturally sensitive, professional, interpersonal, and interviewing skills, basic knowledge of basic crisis counseling, and resourcefulness in locating contacts and networks. qualified workforce will then proceed to conduct the 4 phases of standard contact tracing. The first phase is patient identification and follow-up, which requires interviewing the patient about the symptom, onset, and referring them to support services. Next is contact identification, wherein close contacts will be identified. Then, contact notification, wherein identified contacts will be notified. And once notified, contact follow-up will be initiated. Contact status will be evaluated, self-monitoring guidelines will be administered, and tests will be undertaken if necessary. Those with no symptoms will be required to self-quarantine for 14 days and will be referred to testing. Meanwhile, contacts with symptoms should immediately isolate for 10 days after symptom outset and be referred for testing and support services. However, regardless of the results, contacts will still be required to self-isolate for 14 days as advised by public health authorities. After conducting contact tracing efforts, the collected data should be integrated with testing and treatment procedures, as well as with wider data management systems to facilitate real-time electronic transmission of data for public health action. The fifth area involves isolation and quarantine, which aims to protect patients and those around them from exposure, hence preventing the further spread of the virus. While both measures are important in protecting high-risk populations, these two are different in nature. The concept of isolation separates infected individuals from people who are not ill, while quarantine limits and restricts the movement of individuals who may not have been exposed to an infected person as a precautionary measure. With the number of positive cases observed to rise, health facilities are expected to experience capacity concerns. To address such issues, local chief executives are directed to identify government facilities that may be temporarily converted into COVID-19 isolation and quarantine centers. These facilities shall then be consolidated by the resource management and logistic groups of the National Task Force. The DOH-DILG Joint Administrative Order No. 2020-0001 provides comprehensive guidelines on establishing local isolation and general treatment areas, also known as Ligtas COVID centers. According to the guidelines, all local isolation and quarantine facilities should supply the following: provision of basic room and board, case management limited to symptomatic treatment, monitoring and prompt referral at the first sign of clinical deterioration, and discharge instructions for continued home care and follow-up. For Ligtas COVID centers to operate effectively, LGUs need to comply with the following requirements. The first is space. It can either be a permanent or temporary structure, like a school or multi-purpose hall equipped with utilities and basic amenities. Each probable case of COVID-19 must have their dedicated individual room with its own toilet and bath, and in case individual rooms are not available, beds must be spaced at least 2 meters apart. The second requirement would be a well-trained staff, which comprises 1 manager, 1 sanitation officer, 1 facility physician, 2 nurses or midwives, 1 barangay health worker, 1 data manager, and 1 security officer. The staff should be trained on infection control measures and proper use of PPEs, which leads us to the third requirement: supplies. Personal protective equipment such as protective masks, gowns, gloves, eye protection, face shield, aprons, and rubber boots shall be provided and utilized as needed. The fourth requirement involves special services. It includes providing power for recharging electronic devices and mental health and psychological support devices. The last requirement is financing, in which LGUs establishing Ligtas COVID centers may utilize appropriate funds, including the 20% Development Fund of LGUs, the Quick Response Fund of the Local Disaster Risk Reduction and Management Fund, and the Bayanihan Grant to cities and municipalities. When isolation facilities have reached their maximum capacity, individuals can self-isolate at home. Home-based isolation should be in accordance with the following guidelines set by the American College of Emergency Physicians. First, the patient should avoid social gatherings and ensure other household members won't stay in the same room as you. Next, patients should perform proper hygiene, such as practicing regular hand washing and cough and sneeze etiquette. A patient should allot a separate trash bin for PPEs and other consumed hygiene items. Sharing personal and household items is also not advised. And lastly, the patient must keep their surroundings clean by disinfecting surfaces regularly, especially those near the proximity of the individual under self-isolation. Proper use and disposal of gloves are also advised. And lastly, with the COVID-19 pandemic, solid referral system is essential to connect different healthcare providers within a specific area for a coordinated, cost-effective, and efficient delivery of healthcare services. Depending on the level of care needed, there are various levels within the referral system that the LGU can refer to for the optimal use of health facilities. A barangay health station or barangay health center is the first step in the provision of basic preventive and promotive services such as health education, immunization, sanitation, and even prenatal and birthing services. Rural Health Units or RHU is the second step, then followed by district hospitals. If district hospitals cannot accommodate a patient, they will be referred to a provincial hospital for treatment. In cities, the Barangay Health Center is followed by the City Health Office and then the City Hospital. The highest level of healthcare for both rural and city areas are the regional medical centers, which are facilities staffed by trained specialists, subspecialists, and other licensed physicians and equipped with highly specialized ancillary diagnostic therapeutic equipment. The DOH prescribed referral algorithm for handling COVID-19 cases follows the same movement across the levels within the referral system, but this time, it includes step-down facilities. Aside from ensuring the continuity of basic health services, primary and secondary facilities can also perform the initial assessment and segregation of potential COVID-19 patients. For mild cases that do not require hospital admission, they can either be transferred to the government quarantine facility or be advised for home isolation and be monitored by barangay health workers. Meanwhile, moderate, severe, or high-risk cases must be transferred to the designated COVID-19 hospitals to undergo further testing and monitoring. Critical cases can be admitted to the hospital's intensive care unit or ICU, while less severe cases can simply be admitted as inpatients. Temporary Treatment and Monitoring Facilities or TTMF has the capacity to provide outpatient services as needed, but services are not only limited to supportive medical treatment like monitoring. Those who are suspected, probable, and confirmed COVID-19 cases who cannot observe proper home isolation can be admitted in a TTMF, wherein they are provided with food and psychosocial support. However, TTMF staff has to follow the established guidelines before admitting or discharging the patients from the facility. A patient is for admission if they have mild symptoms, aged between 18 to 59 years old, and without comorbidities. On the other hand, a patient is discharged if they exhibit no symptoms, complete the 14-day quarantine period, and obtain clearance from the attending physician. To provide an effective and efficient health facility referral system within Metro Manila, DOH launched the One Hospital Command Center or OHCC headed by Health Undersecretary and Treatment Dr. Cesar Leopoldo Vega. The command center will reduce the waiting time of patients by referring them to available and appropriate facilities. Likewise, the center will provide medical transportation and patient pickup arrangement to ensure patient safety. The center can be accessed in 3 ways. First, by downloading the Pure for Citizens application. Second, by calling OHCC dedicated lines which are indicated below. And third, by scanning designated QR codes.